This is the result of our patients or the demographics. You can see that we have patients in our series as young as 39-year-old. This is a patient whose father and grandfather had prostate cancer, extremely young. And it's not unheard of to see early 40s, mid-40s come to the office, early 50s. So it's not the old man disease anymore. A lot of you are educated, you read about it, there's screening, and that's how it is. It's rare to operate on a 78-year-old, and we have like very few 78, 75, 74. I don't know if there's anyone in the room who's over 73 who had robotic surgery. That gentleman, how old are you, if you don't? 75-year-old. So it's not like every day that I operate on someone that age, because the book says that after 70 you stop, which I completely refuse to accept, because it's not like years ago where 71 is old and 69 is young. That was like during Patrick Walsh and Calalonos. Now we see men are living longer. They're coming at the age of 73, 76, asking for Viagra. They are taking care of themselves better. The hypertension is not there. So you have to, again, individualize the patient. At the same time, if a 50-year-old comes to me who has had stents and has diabetes, hypertension, and I feel like he's too of a high risk, I may not operate on him. And that's really the key. You can see the comparison of the blood loss compared to open lap robotics in other institutions. The blood loss here is really minimum because we're not wasting too much time in the operating room. There's not a lot of drama, give me this, give me that, I need this. Having a whole baseball team where everyone is in their position, with Alex, with IV, with everyone else, they know what I want. So I don't have to wait for it. If you're not taking this 1.5 hour surgery and turning it into 8 hours, you're not going to lose blood. As far as the positive margin, I think a lot of the reason why our numbers and positive margin is low has to do with the experience of open surgery, paying attention to the oncological aspect of it, and that's very competitive compared to other modalities. So you're not compromising your cancer cure rate by doing this technique in our hands. Not every robotic surgeon, not every robotic institute. And so those are the questions that you need to ask when you find out. Now, this is a great slide to really understand why we remove the prostate. You've seen that, in about 30% of the patients, 33.6% of the patients, you go in pre-op or before the surgery, it's Gleason 6, low volume, 5%. Surgery is done, I call you and I'll tell you that your Gleason score is 7. Well, what happened? Why was it such a increase in the Gleason score? Before the surgery, your pathologists are looking at few glands. And again, we talked about the fact that it's very subjective. You can give 3 to some of that Gleason score diagrams. I can give 4 that can change the number. When you remove the whole prostate, you finally know, because you're looking at the whole specimen, what kind of Gleason score you have. And that's really a major information with this.